Thank you, Senator Alsbrooks. Dr. Littles, what effect does documentation reporting requirements have on the willingness of new physicians to practice in rural or underserved areas?
So, thank you. So we've been talking about the stressor of dealing with the electronic health records and the number of electronic health records that physicians often have to go through in the course of taking care of their patients. When you extend that out into rural communities, oftentimes even access to an electronic health record in and of itself it's costly, but sometimes that's difficult for them to even have. But when they have that electronic health record, we know that the number of clicks that they have to go through to provide that documentation is directly related to the stress that they feel from that. So when you're asking about how that documentation specifically is affecting students wanting to go into rural practice, among the whole list of other factors that prevent them from doing that, that is certainly one of them. And so the cost of the electronic health record, the complexity of using the electronic health record, the fact that the electronic health record isn't communicating with the physicians they're referring patients to in nearby urban areas, all of that has a negative impact. And I hear my faculty talking all the time about the pajama time that they're spending on that electronic health record, which has also been mentioned today. All of those are distractions from the care of the patient.
Thank you. Dr. Gross, tell me how your practice changed. How is your day different now from when you're running an insurance-driven practice to a patient-driven practice?
Yeah, so when I have a fee-for-service practice, any slot in my schedule when I walk into my office that's not already filled is lost revenue. So when I walk in, the schedule's already full. And as the phones start to ring, then I have to start adding double booking, triple booking, quadruple booking, referring to the emergency room, sending to physician assistants, nurse practitioners, sending to other sites of care, because I don't have the capacity built within my schedule to accommodate for them, which requires me to run an hour behind schedule, 2 hours behind schedule, 5-minute office visits, 3 minutes of those which are spent clicking the boxes to get paid, and then the 2 minutes, oh, you've got another problem? I'm sorry, you got to rebook, and by the way, my next available appointment's in 3 months. My schedule that I have right now is I walk into my office. I have an hour before lunch blocked out for same-day appointments, an hour before lunch at the end of my day blocked out for same-day appointments. And as the phone rings, if you call me in the morning, you're seen in the morning. As you call me in the afternoon, you're seen in the afternoon. And if I don't get a phone call, then I do administrative time, or I go home and spend some time with my family. But people aren't referred to the emergency room simply because I'm too busy. And that opens up my schedule to actually practice to the full scope of my training. So I would argue that a lot of referrals in primary care, not because the doctor's not capable of handling the problem, it's because the doctor doesn't have time to handle the problem. So when the doctor now has the time and the administrative burden is lifted to perform the full scope of his or her practice, now you're stopping downstream referrals for endocrinology, for rheumatology. You're managing things within your practice that are clearly within your purview as you're training. And we see that in our data, that when we implement this into a health plan that's built around our practice model, our ER referrals are 35% less. Our specialty referrals are 35% less. Our cost of total implementation of the health plan built around our model is a 52% reduction in healthcare in a rural healthcare setting. And we've sustained numbers like that over 7 years because not because we're better than anyone, it's structural design of the practice. It's the administrative design of the practice, the intent of that, which I think is completely changing how we care for patients.
Thanks. Mr. Smith, how much of your budget goes to getting prior authorizations, compliance, paperwork versus patient care?
Well, that's a good question. I don't have a specific answer. I can tell you that in 75 offices, we have at least one employee, average employee with benefits is making $35,000 to $50,000. So it's a significant amount. And if we could reduce that by a quarter, by a half, it would significantly change the budget of the medical group.
Is it easy to stay with all the changes by the insurance companies and by Medicare and by Medicaid?
I'm sorry, Sid?
Is it easy to stay up with all the rule changes by Medicare and Medicaid, plus all the changes with the insurance companies?
It is not easy. I mean, we do our best to educate. We have great staff. Our staff typically is high school educated, working in the medical offices. We have in-house programs to allow them to become certified medical assistants. We do everything we can to raise them up and to increase their knowledge, but it's a lot. It's a lot. One or two doctor practice, can't really have a business manager running that practice. So we're running it from afar and hoping that we can get information to them to allow them to be successful, honestly, just to get paid for the work they're doing.
The people that run Medicare and the Medicaid in your state, they're just out there to help you every day, aren't they? They're just
Yeah, every day they come out. No, it's a challenge.
Yeah. Mr. Feist, how much of today's mental health crisis is driven not by patient care itself, but by the constant pressure of bureaucracy and red tape?
We hear that as we've discussed today, when you think about burnout as an occupational syndrome, and burnout is driven by the workplace design, I think as we've discussed today, the vast majority of what we're experiencing in burnout is within our control to reduce by changing the operational environment that our healthcare workers work in every single day.
Good. Thank you, Member Gillibrand. Do you have anything else? Okay. Well, I want to thank everybody for being here today. This was eye-opening. Hope all of our colleagues in the Senate see all this. I think it's very difficult what physicians are going through. And I think more and more physicians are doing what you're doing, Dr. Gross. They've got to opt out of the way the system is organized because it's just too difficult. And I'm sure you deal with Dr. Littles all the time, the choices people are making. So thanks everybody for being here. It's clear that real reforms must start with cutting red tape and putting doctor-patient relationships at the center of healthcare so physicians can focus on healing rather than compliance. I look forward to continuing to work with members across the aisle and down the dais. If any senators have additional questions for the witnesses or statements to be added, the hearing record will be open until next Wednesday at 5 p.m. Thank you very much. It's adjourned.